Hello, everyone. Welcome. Nice to see some familiar faces, and welcome also to the many who are joining us online. And specifically to this event, Corruption in Healthcare, a Global Health Blind Spot. A rather uninteresting and uncontroversial topic, as we can tell by the fact that we've had more registrations than for any other event we've had. And I wanted to thank specifically Ellen for having the courage to put this topic out there. So we know that this is a sensitive issue. It is not uncontroversial at all. It's been referred to as the greatest threat to global health, a disease in health systems, and the elephant in the room. As someone who has seen, just to tell a 10-second anecdote, I worked in DRC during the Ebola epidemic in 2018, and some of you will recall that the response was engulfed in violence with bombings of treatment centers and killings. And I think I can quite safely to say that the origins of all that violence was corruption. I wrote about it. So it is a very real issue. It's not an abstract accounting problem. It is one that bedevils our global health efforts. And the reason I think we want to bring it out into the open is that it really is a major issue, and it deserves to be understood and addressed. It is considered one of the most important barriers to implementing universal health coverage and the SDGs. So there's an article in The Lancet, the link is in the chat box, which engages with this issue, introduces it. A few logistical comments. Have I introduced myself? No, I haven't. Sorry. My name is Vin Kim Nguyen, and I'm the co-director of the Global Health Center, with Suri Moon. And so yes, that's me. I will disappear because I'm actually not part of the program. You have much more knowledgeable and interesting speakers who will be part of the panel. So link to the article in the chat box. The recording will be available on the Global Health platform in 1 to 2 days, and a short video of the key messages, so for people who don't have the time, will be available in a couple of weeks. Thank you, Bettina, our communications coordinator who organizes all of that. If you have any questions for the Q&A, you can enter them in the Q&A box by selecting panelists and attendees. You can address this question to an individual speaker if you want. And please type any comments in the chat box, including any addressed directly to an individual speaker. So finally, I am delighted to introduce the moderator for this event, Pratik Patnaik, who some of you know as the founder of Geneva Health Files, which contains all kinds of salacious tidbits and accounts of all the stuff that's happening backstage. So Pratik, thank you for joining us, and over to you.
Thanks so much, Vin Kim, and welcome to this event. Today's speakers will discuss corruption in the healthcare sector and how it affects global health. And as he said, the reason we are discussing this is we know the importance of health systems strengthening and its importance for universal health coverage. And this means protecting and leveraging investments in health. But there's a problem because all of these investments are at risk because of health system corruption. And the Lancet article that he referred to actually suggests that of the $7 trillion spent on health services globally, 10 to 25% are lost annually through corruption. And that amount actually exceeds the investments needed to achieve UHC by 2030. So our speakers will shed light on how corruption affects healthcare and what can be done about it. There'll be two formal rounds of questions for the speakers, followed by a Q&A open to all of you here in the room and online. And our speakers today are David Clark, WHO Acting Unit Head, Health Systems Governance and Policy, Dr. Ion Bahnarel, Professor at the University of Medicine and Pharmacy, and is also the former Deputy Minister of Health, Republic of Moldova. Mushtaq Khan, Professor of Economics at SOAS, London, who will speak online, and Dr. Monica Kiria, Senior Advisor at UFO Anti-Corruption Resource Center, who will also join us online. You can find their full bios on the event page, and it's now my pleasure to ask David to set the stage. Thanks. Dr. Ivan, you can also join us on stage.
Thank you for that kind introduction. So I'm David Clark from WHO headquarters in Geneva. One of the topics that we work on in our governance work at headquarters now is corruption. And for a long time, this wasn't a topic that we could work on comfortably. We used to talk about corruption in WHO with all sorts of euphemisms like waste and leakages. So we didn't really get to grips with what we were actually talking about. And I'd just like to ask you a question. In your personal lives, if you had a problem which affected your financial well-being, it was a threat to your life, and was a threat to the way that you lived, would you do something about it? And that's what corruption actually is all about. When it comes to corruption in health systems, it's actually, I think it's well described in the Lancet article as a disease of the health system. So in terms of all our work on health system strengthening, unless we address this problem of corruption, a lot of this work is just a waste of time, in my opinion. So just to quickly go through some key ideas from our thinking about corruption. I think I'm just trying to work out how to run the technology. Oops, sorry. So just in terms of what corruption is and its consequences, how we have tried to find a way to work on corruption. It's a difficult topic to work on. A couple of years ago, there was a special series of articles called Why We Need to Talk About Corruption. And if you haven't read those articles, there's about 20 of them. They're written by various academics and practitioners who talk about why we actually need to deal with this topic. For a long time, we just haven't. The people who have dealt with it have tended to be the agencies that work on criminal activities, such as the UNODC. But it hasn't really been an aspect of health system strengthening at all. So a couple of years ago, we started to do work seriously on it at WHO from a health system strengthening perspective. And recently we set up a global network called GNACTA, and that's a mouthful, the Global Network on Anti-Corruption, Transparency and Accountability in Health. And the reason we set up a network is because it's such a multifaceted and complicated problem that we thought it was really important to have a number of different agencies who brought different perspectives to the topic. Human rights perspectives, anti-corruption, fraud perspectives, but also WHO who brings a health perspective. And collectively we thought it was much better to be able to come together and to work on this topic. But I think the first thing I wanted to set the scene is what we actually mean by corruption, because it's not a word that's well understood. So the official definition of corruption is on the left-hand box. It's the abuse and complicit abuse of power. And this comes from a UN declaration. So there is a UN declaration on corruption, anti-corruption rather, which has been signed by almost all of the UN member states. Usually it's seen as focused on acts which are legal or illegal, but it's complicated because it's a concept which is very much bound by context and by culture. In some countries, some things might be regarded as corrupt when they're not in other countries. So to give you an example, in some countries it's customary for people to give gifts to health workers after they've helped with some healthcare. But in other countries, that might be regarded as a corrupt act. So it's complicated, and it's very much driven by context and as I said, by practice. And it's often difficult to agree on what is and isn't corruption in relation to that very complicated cultural context. The other thing that's often spoken about when it comes to corruption is sometimes it can actually be a form of adaptation. Sometimes it's a way to make things work. So people might act in a way which some people might describe as corrupt, because it's the only way to get things done in health systems. So as you can see, it's quite complicated. It's not something that's easy to understand or to get your head around. But we think we need to do a lot more to understand what it is and what its drivers are. And that's why we want to do a lot more work to talk about corruption. So it's great to have you all here today, and hopefully you'll start to think more about this topic and to talk about it. We want to understand what its drivers are and what vulnerabilities and manifestations in the health system affect it. So it's all very well blaming people and saying that they're corrupt or whatever, but quite often corruption is driven by underlying forces in the health system that need to be understood and addressed. So just to give you a little bit of a sample of the sorts of things that are regarded as corruption, this is from various academic material, and also from our work, and also from the work of other UN agencies that work on this. So there's a whole range of different activities regarded as corruption. There's informal payments, there's absenteeism, there's data manipulation, there's lack of transparency, there's falsified medical products, there's embezzlement, there's bribery. There's a significant range of activities which could be regarded as corruption, and all of them have one determining feature. They all distort health systems, and they all affect the way in which people receive health services negatively. So I think in the opening we talked about the Lancet article, which talked about corruption being a disease of the health system, and it really is. And if you look at the corruption literature, the health system is actually the most corrupt in terms of all the social sectors for a number of different reasons. But I guess because there are so many complicated interactions within health systems, and also because there's so many resources involved. And just talking about the consequences of corruption, and we touched on this in the introduction. Some people estimate that at least 7.3% of health spending worldwide, and as much as 80% of non-salary health funds never reach health facilities. So we're losing nearly 10% of health expenditure to corruption. And if we had that money, can you imagine how much further closer to the SDG targets we would be? So it's a massive problem. And in terms of giving it some colour, it's estimated that 140,000 children die every year because of corruption. I met a person at an anti-corruption meeting last year, and I asked them why they got into anti-corruption work, and they told me it was because they lost a family member because of corruption. So it's an issue that really does affect people's lives. It also negatively impacts on access to treatment and care. There's evidence that shows it perpetuates antimicrobial resistance. So, it's an incredibly serious health system problem. It creates all sorts of negative impacts in relation to the health system. And at WHO, what we've tried to do, because we are a health agency, we're not an agency that's looking to catch people or to act in a policing role. We're very much wanting to frame corruption in terms of a public health problem. So it is a public health problem. It causes all of these problems that I talked about in terms of the health system. And framing it as a public health problem, we think, helps shift the focus more towards downstream and preventive action in relation to anti-corruption, and focusing on how anti-corruption mechanisms contribute to better use of health resources makes it a much more easy. It's a complicated topic, but it makes it a much more politically palatable topic to deal with. And we think that if we do that, we can look at the underlying drivers of corruption in the health system, whether that be poor standards or insufficient money for health workers, and we can look at how we can address those underlying drivers and causes. We also think, and I mentioned the GNACTA network, that there's a great deal of potential to build anti-corruption coalitions across different sectors. So just in terms of thinking about this as a public health approach, we're very much, it's a little bit like anti-corruption epidemiology. What we're trying to do in our work is really understand the nature of the problem, both the technical nature of the problem, but also the political economy of anti-corruption. Corruption is a problem which is rife with political economy issues. We also want to try and examine why corruption occurs in the first place, identifying risks and protective factors that can influence it. We're busily developing and testing anti-corruption prevention strategies. And here I should mention that there is actually a lot of literature that looks at what's effective in relation to anti-corruption, but so far we haven't actually found very much that actually is. So there's a lot of work going on at the moment to test new approaches. It's shocking. And I know I can see people in the audience laughing about it, but it is actually shocking. We don't actually know enough about how we can work on this topic. And we also need to do more, I think, to integrate action research and evaluation into these different trials and ways of thinking about how we can address anti-corruption as we take the topic forward. So I just want to briefly mention the network that we've set up. So we have this network called GNACTA. Anybody can come up with a better name, we would work. But our idea, the impact of the network is to try and create more transparency and accountability in health systems, but ultimately to improve health system performance and better health for all. So we are very much focused on working with our strategic partners. On the right-hand side, you'll see a list of some of them, and we're building the network as we speak. So at the moment, a lot of the strategic partners are UN agencies, but we're certainly reaching out to anti-corruption NGOs and other partners like Transparency International, and also academic partners. And the other thing I wanted to very briefly mention is that it's looking increasingly likely that this year there'll be a Lancet Commission on corruption. So that will be an opportunity, I think, to really raise the profile of the issue as a health system strengthening problem, and hopefully to make more progress on talking about corruption and talking about what the anti-corruption solutions might be. So thank you for your attention, and I'm going to pass over to people on the panel who know a lot more about this topic than I, and will be able to give you some nice concrete examples of the nature of the problem. Thank you very much for your attention.
Thanks so much, David, for setting the stage. Lots to chew on already. We'll go over to the first round of questions. Before that, I can just invite Dr. Bahanarel to join us. So our speakers will have a maximum of 3 minutes to answer each question. I'll gently remind you when 3 minutes are up. We first begin with Mushtaq Khan, who's joined us online. Mushtaq, how do countries actually define what is corruption in the health sector and what is it not? And to what extent do you think corruption is really a result of lack of resources in a country's health sector? Can you hear us, Mushtaq?
So thank you, and I'll just pick up some of the things that David was outlining. So countries don't have a specific definition of corruption in the health sector, but we know what corruption means. It means the misuse of power for personal benefit. And when surveys are done in countries by agencies like Transparency International and others, and people are asked, what is corruption in the health sector? I think citizens have no problem in identifying what is corruption in line with that kind of understanding of a misuse of power. So I'll give you a few examples, and then we'll talk about what might be the causes. So the first and most glaring example of it is the theft and diversion of resources by the agencies in control of health spending, which could be the ministries and divisions and departments, particularly in issues like procurement of medicines and equipment. So, for example, it's very common in developing and emerging countries that equipment is purchased, which is excessively expensive. And not just that, a lot of equipment might be purchased, which is not usable because the skills and the technicians don't exist to use them. So they lie in their boxes and rust. Now, that is a massive kind of example of misuse of resources, or medicines might be procured which are overpriced, and medicines might be procured which are out of date, and so on. So this is the first example of theft and diversion of resources, which is really glaring. Then you have a second type of problem, which is political patronage in the appointments of doctors and health service workers, where you have political parties and governments and so on, which use influence to get appointments for their favored party supporters and so on, which can result in the selection of less qualified and sometimes people who are not at all interested in being health workers. The third type of problem example is the problem of absenteeism, which David mentioned, which is massive. In many countries, 30 to 50% of health workers might be absent from particularly rural health clinics at great cost to the citizenry. Now, these are people who are violating their employment contracts and getting away with it. A fourth example is overpricing of medicines by pharmaceutical companies and aggressive selling by sales agents who often illegally use bribes to get doctors to overprescribe medicines or to prescribe expensive medicines. And this is, again, very common. In many developing countries, 60% of health spending is out of pocket. That is, patients are paying for it out of their pocket, and most of this out-of-pocket spending is medicines. And finally, the kind of most obvious example of corruption, this is by no means a kind of complete list, is what is often described as informal payments, which is a nice word for bribes, where citizens have to pay bribes to get a bed or to get seen in a hospital. And this is different from gifts after you have been treated. I mean, David was referring to that. That might be a cultural practice, but in no country is it a cultural practice that you have to pay a bribe to get a bed or get seen by a doctor. Now, to complicate matters, these different types of corruption might each have multiple causes, and this is where it gets really tricky. So you mentioned lack of resources. Lack of resources is indeed one factor driving corruption. So if you are in a hospital which is under-resourced, then there is excess demand and people have to pay to get seen and so on. So some corruption is indeed driven by lack of resources. But that is not the only cause by any means. So political clientelism and patronage is another driver of corruption. So the way in which patronage is used to create jobs and so on is not directly to do with resource scarcity. The third and really important problem is that these are societies, many of these societies have a weak rule of law. And that means that enforcement is weak. And that is a factor which is severely important because it means that transparency, even when you know who is violating and how the violation is happening, often nothing happens because the transition from transparency to accountability and enforcement is very weak. So in those kinds of countries, the kind of standard answer to corruption, which is transparency and accountability, doesn't work because even transparently corrupt things continue in operation. And some corruption is due to the rules being inappropriate. So sometimes the rules have been set up in such a way, and David mentioned that, there is no way you can operate without actually breaking those rules. So sometimes doctors and health staff have to break the rules to operate because the rules weren't set up in the right way. Now, the problem is that when you have these multiple causes operating on top of each other, if you take any particular type of corruption, you might have multiple causes. So take the issue of absenteeism. Absenteeism might be partly caused by the wrong people being appointed because of political patronage. It might be caused by people paying bribes to get jobs. It might be caused by weak enforcement and a weak rule of law. So even in countries where you have fingerprint monitors to monitor doctors who are absent, something happens to them after they have been identified. And it might be because of bad rules. So in some countries, you have, in Bangladesh, for example, you have rules where junior doctors are sent to the boondocks. And if you're a female doctor, for example, you might feel very insecure going to some of these areas where there's very little security, and those rules are just wrongly constructed. So when you have these multiple causes and you are dealing with a problem like absenteeism, the way we do our research in SOAS ACE is we first try to get a fix on what are the different drivers of a particular corruption problem like absenteeism, and then we ask,
Mushtaq, if I can just ask you to wrap up.
Yes.
We'll get into these issues in more detail shortly.
Okay, so basically, when you have these multiple factors, you need to separate them out, and you need to identify which ones are feasible to address. So we can't address all problems immediately. We need to address some high-impact causes of problems, and we need to find ways in which self-enforcing solutions can be devised. So that is our approach to identifying really or breaking up really complex problems into bits which can be solved. Thank you.
Thanks a lot for giving us the high-level big picture on how this looks like, a bird's eye view in some sense. Dr. Bhanarel, if we can, get to know from you more in terms of, what it was trying to introduce some of the most important anti-corruption reforms in Moldova. Clearly, bribery in frontline delivery of health services is a major problem, not just in Moldova, in many different parts of the world. So what kind of actions did the government take? And if you could actually focus on the three most important reforms, why they might have failed or why they succeeded. Thanks.
First of all, thank you very much for invitation for so interesting and important event. And Professor, thank you for perfect presentation in the field. In my opinion, corruption exists on Earth as long as Homo sapiens exists. And I think it will exist until humanity build paradise in the earth. The level of corruption and its extent has historically depended of not only of socio-economical, political system, well-being of the population, access to food, drinking water, medical services, medicine, but also on the culture, tradition, and custom of community and people. After independence, to a large extent, corruption is the result of the lack of resources in health sector of a country, which entailed the lack of modern medical technology and the lack of access to them, the lack of or insufficiency of medicine, including lack of resources for prophylaxis program, especially for immunization, and very extremely low salaries. At the beginning, our salaries were more than $100 for doctors. In our country, the definition of corruption is more or less as was here, but exactly this definition represents those limiting acts resulted by law, such as taking and giving bribes, receiving benefits, influence, constitute the illicit activity carried out with aim to obtaining material and moral advantage of high social and political position. In order to eliminate this event, the government have initiated several reforms in anti-corruption system, including the formation of central and local state structure on anti-corruption. Anyway, the government has, our government very quickly changed one after one. Anyway, the last government has undertaken various actions to prevent and combat corrupt behavior among employees of medical institutions, and our today President Maya Sandu declared zero tolerance to corruption for all, inclusively from doctors. And it was the hearing principle was revised. For the employer, the job description were revised with the exact establishment of the job duties. The managerial internal control works in each institution. Box applies in institution where employer and patients can anonymously inform the administration of deviation aspect of corruption. Ethics committee operate in each institution. The rule and procedure regarding public health requirements are very clear established. In this committee work not only doctors and economists from medical institution, but obligatory for anti-corruption committee for Ministry of Internal and other ministers. And in all institutions, for the purpose of transparency and conclusion of responsibility, there are registered of evidence of gifts, conflict of interest, Here, the work need to be activated. There are shortcomings in our country now. Thank you.
Thanks so much. We'll probably revisit some of these themes later in the session. My next question is to Monica. You've done research on corruption in Uganda. What has your research revealed about health workers being both perpetrators and victims of corruption? And more generally, how does it actually affect the life of Ugandans seeking healthcare? And maybe you can also talk a little bit about the common misconceptions about corruption in service delivery in a typical sub-Saharan African country like Uganda. Thanks.
Thank you. So I'll start with the part on how corruption affects the lives of Ugandans seeking health services. I think it's safe to say that you could die if you don't have money to pay a bribe, to move up the queue, to see the doctor, especially if you come to the hospital and you're in an emergency and you're a poor woman in labor and you have no cash on you to pay for the common, code for an informal payment, which is money for gloves or something like that. So, of course, cases have been filed in Uganda's courts about this problem in maternal services in Uganda. And so, really, it's obviously a dire situation and really discouraging that if you don't have money to pay a bribe, your life is in danger. But also, as you said, I think that it's important to not just paint health practitioners and health workers with a broad brush as evil, self-seeking people who are just not doing their jobs properly. I think it's well known that in many developing countries such as Uganda, health workers are extremely poorly paid. And Mushtaq already touched on the fact that this is one of the drivers of absenteeism, informal payments, and other types of corruption that health workers engage in to make ends meet. Of course, this doesn't make such forms of corruption okay, but we can sympathize with the health workers and the dire conditions they work in. So in terms of them being victims as well as perpetrators of corruption, I'd like to also shed light on another thing that's less discussed in anti-corruption circles, and that is the structural factors that enable corruption to thrive. During my research with some medical doctors in Uganda, we found that one under-researched causative factor in the Ugandan health sector was a ban on public service recruitment. These bans on public service recruitment started under structural adjustment programs that were started in the 80s and 90s to reduce government expenditure, and they still remain in force from time to time as a way to balance the public budget. So, of course, this creates a perception, in fact, a reality of job scarcity for medical graduates. And let's not forget that Uganda is one of the countries with a massive youth bulge. Uganda has the world's youngest population, with over 78% below the age of 30, and around 8 million people aged between 15 to 30. So this creates a massive, massive dependency burden and also a very high unemployment rate. So, of course, there are more graduates than there are available jobs. And what Mushtaq mentioned about political patronage being used in the recruitment and appointment of health workers goes hand in hand with extortion and bribery. When district politicians, because health is a decentralized service in Uganda, and recruitment is often done at local government level. So district politicians and district civil service administration use recruitment to extort money from medical graduates These bribes can be really, really large. We are not talking small money. We are talking thousands of dollars, $2,000 or more, a sum that's way out of reach for many ordinary Ugandans. And you have graduates who are borrowing money from unscrupulous money lenders to pay these bribes so that they can be recruited. And once they're recruited, you would think that this would be the end of the extortion, but no, you need to be entered onto the public payroll. And to be entered on the public payroll, you find that, again, medical recruits face another situation of having to pay bribes. And during research carried out by one of the medical doctors I worked with, which research was done under PEPFAR, the Presidential Emergency Fund for AIDS Relief, they found when they interviewed some doctors that some took up to 2 years after recruitment before their names were entered on the payroll and to receive their salaries. And when they did finally get onto their payroll, they didn't even get their arrears, and these were embezzled. So you can imagine not being paid for months, for years even. Of course, it would drive absenteeism. It would drive informal payments, moonlighting, pilfering of medicines, and many other forms of corruption in the health sector. So as previous speakers have said, it is a complex problem, and we have to be able to sort out all the different causative elements. For instance, if we were to lift a ban on public service recruitment in Uganda, have more money in the health system so that there is enough money to recruit all the needed health workers, maybe it could also play a role in reducing corruption.
Thanks so much. Before we go to the next round of questions, I think a few broad themes do emerge that what we understand as corruption in the healthcare sector has structural factors contributing. It's just a symptom of a much broader malaise, as it were, and the political economy of how health is tied to other sectors of the economy is also crucial to note. I'm also glad that you brought up the issue of cut in public expenditure and how that contributes to scarcity, and that drives corruption in some sense across countries. We'll just move to the next round of questions, pretty much in the same order, looking more at the larger systemic issues and looking at potential solutions. Mushtaq, I wanted to know from you, what role do you think high-income countries, multinationals, foreign aid donors play in creating both corruptors and the corrupted, such as in the access to essential medicines? And a lot of what you have said, the speakers have said in the first round, I think a lot of us have stories about how COVID-19 sort of also brought us face to face with corruption in healthcare, no matter where you lived. So maybe you can touch upon that as well. Thanks.
Yeah, no, thank you. So I think that these are complex issues, and it's so what aid and donor support for health systems do, I think, is mainly errors of omission rather than errors of commission. Because I think that particularly people from more advanced countries, when they think of corruption in any context, they think that a few people are breaking the rules, and if you have transparency and accountability systems, you can just catch them and punish them and everything will be fine. So a lot of the effort that has gone into improving systems delivery in developing countries has been to have the flow of funds in the health system supplemented, and then adding on a separate thing called governance. And that governance has been things like better transparency accountability systems or better public financial management systems and so on. And this ignores the kind of systemic stuff that we've been talking about, that actually, if you look at not just the health system, but most people in developing countries, most people are violating some rules most of the time. So if you have that kind of widespread violations going on, transparency accountability by itself is not enough. Instead, what we need to do is to find ways of redesigning the systems themselves so you can strengthen the checks and balances so that you have better delivery of outcomes. This is something that actually most donors and most aid programs completely ignore, they think of governance and health, or governance and education, as two separate things, whereas in fact, they have to be embedded in one another. So this is what I would say is an error of omission, and that has actually supported a lot of misguided kind of investments in anti-corruption, which haven't really borne fruit, and has created frustration and even irritation with anti-corruption in many developing countries. The second question you had is about the role of multinationals. This is extremely big problem because the research and the driver of new innovations in pharmaceutical products happens with very big companies who earn massive profits from intellectual property. This is actually necessary because developing medicines takes a lot of money. The issue is that this intellectual property is protected by, in the minds of many economists, the protection is for too long and too unconditional. And big pharmaceutical companies protect these interests with a lot of legal lobbying in advanced countries. And some of this legal lobbying has a kind of, is a kind of corruption because there's a misuse of power. And so a lot of the intellectual property rights protecting pharmaceutical products is excessive and prevents the development of pharmaceutical capacity in developing countries. So that's one problem. The second problem is that pharmaceutical companies in developing countries are also very powerful. They usually contract producers for advanced country pharmaceutical companies. They are themselves very powerful and often politically connected. And there's a lot of issues with overpricing of medicines. And I mentioned earlier how aggressive marketing is used to oversell medicines and so on. One of the really important issues in opening this up is how we can find feasible ways of opening up competition in pharmaceutical markets. This is not easy. And I think the answer is not just locating more production in the South, and this has been one of the lessons that we have learned from COVID. It's not just that, because many of the producers in the South have often been politically captured and not been able to provide the medicines in time. What we actually need is to have a more broader base of production in the South, which includes what I would call social enterprises. That is, enterprises like in Bangladesh, we have an enterprise called GK, Ganashastro Kendro, the People's Health Center, which manufactures medicine, but on an almost not-for-profit basis. We need to think really about opening up manufacturing on a not-for-profit basis in developing countries. And there are examples of this, including in countries like Bangladesh. And I think that is necessary to reduce some of this political capture and legal corruption in the form of lobbying that protects large pharmaceutical profits. And I think that's one of the lessons that we learned from COVID. So COVID has been a glass half full and a glass half empty. It has been remarkable how quickly new vaccinations were discovered as a result of these massive incentives. On the other hand, the rollout of these vaccines in developing countries was often constrained by lack of supply and political issues. So I think...
Can we just wrap up before we go to...
So I think for me, the main lesson from COVID-19 was that it revealed that years of corruption and underinvestment in the health systems in developing countries in particular, but not just in developing countries, has meant that the health systems have not been able to respond to a big crisis like COVID-19. I think this is a really big lesson of COVID-19. Thank you.
Thanks a lot. Lots to unpack. I think discussing legal lobbying is a whole different session in itself. Before I come to Yvonne, I'll just go to Monica to stick with this theme of the role of politics in perpetuating systemic corruption in the health sector. Maybe you can take this this reality of state capture of health systems and potentially having linkages to election systems, for example. You could probably elaborate a little bit on that, Monica.
Yeah, sure. Thank you. So in many newly democratized countries in sub-Saharan Africa, that is, countries that adopted multi-party electoral systems of government in the late 90s, early 2000s, under the so-called third wave of democracy, money has become a defining factor in politics, in the sense that those who want to run for elected office at national or even local government level require massive amounts of money for election campaigns and literally buying votes and maybe even buying off opponents. By the time they get into elected office, many politicians are heavily indebted and looking for every means they can to make money, to pay off their debts, and to create a nest egg in case they are not voted back into office. But what does this have to do with health and health outcomes? First of all, if you look at Uganda, for example, during the election campaigns of 2006, Global Fund grants were diverted to fund election campaigns under the guise of immunization campaigns. And this is on record in the report of the Commission of Inquiry into the mismanagement of the Global Fund in Uganda. I don't think that report is still publicly available, but I am fairly confident, as this was one of the issues in my PhD research. So you have money for the health budget being embezzled in order to fund election campaigns. An NGO called the Alliance for Finance Monitoring in Africa, based in Kampala, does research on electoral politics in many sub-Saharan African countries and is of the view that campaign-related spending is definitely one of the reasons why politicians and public officials engage in high-level corruption in all sectors, including the health sector. So they want the kickbacks that they can get from pharmaceutical companies to pass policies that will favor them to make money. They want the kickbacks from the procurement, and medical equipment is very, very expensive, and there's lots of medicine to be made in health sector procurement. So of course, those who see an opportunity to make money from the health sector will grab it. This means that we can't look at health sector corruption in isolation from the issue of corruption in electoral politics. We have to address the issue of money in politics if we are to have any progress with health sector corruption too.
Thanks a lot. I don't know about you, but all of this is a bit depressing. Maybe we can, go over to Dr. Bahanarel. You could tell us something about some of the anti-corruption efforts were driven by grassroots and community organizations in Moldova. Where does change really come from? And, what are the lessons that you can share with us?
Thank you. The first years after independence, the country faced the political, economical, and social crisis, and it vitally needed big help of countries with high income, especially in the field of health, which is still being achieved today. Simultaneously with the countries, multinational companies also provide substantial help, at first free for charge, then with payment of costs, by delivering high-performance medical equipment, including laboratory, generic drugs, medicines, vaccines, test systems, medical transport, means of protection, staff training, and internships, ensuring effective communication with the population. These efforts were highly appreciated by Moldovan people, especially during the COVID pandemic. During the pandemic, corruption did not progress much, but cases of bribery were identified for the procurement of individual oxygenators, individual blood oxygen control devices, antibiotics, performance test system, etc. After the market was saturated, this was needed for diagnosis treatment. Several types of anti-COVID vaccines were introduced. This wave subsided. Effort to hide corruption in the Republic of Moldova continue in all political, economical, and social levels. The media systematically inform about corruption and bribery every day. We have a special TV channel which daily inform about discovered cases of corruption. The Green Line, anonymous information, free legal consultation, in the field, public lessons, meetings with community and civil society, round table, individual work in each group. Overall, the number of corruption cases in the country was decreasing, but new types of corruption related to the war in the Ukraine and the energy crisis have appeared, in which responsible person from the customs services, border policy, information technology services, local public administration have been involved. The fight against corruption is directed and guided by the government and National Anti-Corruption Agency, public order bodies, justice, and of course, the force powering the state, mass media. The critical factors which allowed successes in the fight against corruption are the dedicated staff with professional integrity, the collaboration of the law enforcement agencies, the support of this fight with the state institution, the mass media, and the population. But recently, for several weeks in a row, the opposition party Shor, led by the underworld Ilan Shor, from outside the country and sympathizants from communist and socialist bloc, tried to destabilize the political, economical, and social situation in order to remove the current government, in order to avoid criminal liability for act of corruption, very big acts of corruption. It was more some $1 billion. And those people are abroad now. Why? And the change the European vector of the Republic of Moldova towards to Russian Federation. This is worse. Thank you.
Thanks so much for your comments. Before we open up, the floor for questions, people online, please feel free to, add your questions. We'll just take them in a little while. But just to sum up, I think I'm beginning to get the sense that it's probably an artificial distinction to make when we look at corruption in the healthcare sector, because we are actually also looking at other broader aspects. And David, maybe you can expand on that later. So we have a few questions online, but before we go online, are there any questions in the room here? We have a few questions online already. Yeah.
Thank you to the organizers for organizing this event on an issue which everybody feels it. I think my question relates to the corruption in health sector, which is the title of the discussion today, with the overall corruption environment in a country or in a given society. Transparency International makes a list of the ranking of the countries, how corruption is perceived. It's a perception of corruption, but they bring out a list. I'm pretty sure if a similar work is done relating to corruption in health sector alone, probably the two lists will overlap. The implication is that we may have a lot of issues relating to the corruption in health sector, but probably the correction is not restricted to health sector. It's on the overall society. Means I come from India. I have seen the whole cycle of emergence of real corruption in mid-80s to the current efforts which is going on. It's almost like completing a cycle. And one of the intervention has been that when corruption becomes a high political agenda, then the discussion starts and some of the interventions start top down. Not the operational level, but at least a beginning is made. I'm sorry.
Do you want to take that question, David? And it actually sort of what I was asking earlier, the specificity of healthcare corruption as opposed to the wider?
Well, I think it's unignorable that it is part of broader sectoral issues. It's not just about health. It's often about corruption in government, or it might be in corruption in the education sector, or in different sectors. And the sorts of weaknesses in the system that the panelists have been discussing aren't unique to the health sector. It's just that the health sector tends to be a very corrupt sector. It's more susceptible to corruption because of the nature of the sector. Because you have multiple. A couple of years ago, we did an exercise where we looked at the pathway of a patient through the health system and looked at where all the different risk points were for corruption. And there are multiple risk points. I think that's what one of the factors for making why the health sector is so susceptible to corruption. And I think also we've been talking today about the large amounts of money that come in through development aid. We also talked today about the impact of COVID and all the money that came in around that. And all of these things, when you put them into a system which isn't well set up in the first place to make sure that resources are distributed in a way which is equitable and fair and effective, just exasperates existing problems in the health system. So it's not necessarily something which is an issue of black and white and good and evil. It's actually about inherent flaws in health systems and also inherent flaws in wider governance systems.
Thanks a lot. Are there any other questions from the room here?
Yes, my name is McDougall Hunter. Thank you very much. I'd like to thank you for organizing this, but I'd like to zoom in, just make a small comment about corruption. Please let us not forget, those of us who are from the northern hemisphere, that for corruption to work, it's like a tango. You need two. You need the corruptor and the corruptee. And therefore, I think that when you see one of your sponsors as the World Bank, I should perhaps mention that I worked for the UN for 30 years here in humanitarian and logistics, so I hope to know what I'm talking about. I'd like to ask one question, and above all, thank very much Dr. Mushtaq and Dr. Monica for a very courageous and very interesting intervention. I'd like to ask the question about fakes, fake medicine. Is anything being done about fake medicine? Because in the field, it is a huge problem. Fraud, i.e., and I take the example, like Dr. Monica said, it's a question of local environment, and like Dr. Mushtaq said, redefining systems. If you pay a nurse on the last mile on the immunization circuit to go to the village and vaccinate children, and you only pay her $10 a week, what do you expect? So it's a problem. She goes away, she re-injects water into the vials that have been used overnight. As she's paid per round, she goes the next day, injects that dirty water into children, and she gets paid for it. So I do think my question is simply, you put in your title, a global health blind spot. Well, if it's so blind, why can't we use modern technology to find out a lot of more things? Like IoT, you can track anything, including a vial today. Why aren't we using it? You don't need batteries under a baobab tree, sorry. There's plenty of other ways of doing it today. You don't need plugs in walls that don't have electricity, like the whole of sorry, I don't want to be offensive, but like most of sub-Saharan Africa. Why can't we use technology today to try and find out what's going on and therefore bring remedies to these situations? Thank you.
If I can just add on to that, I think there are a couple of questions online on the question of actually supply chain, corruption in supply chain. And I'll let the speakers respond to the question in the room as well. Mushtaq or Monica, do you want to jump in?
Yes, sure.
Yeah, go ahead, Monica.
Okay, I can speak about fake medicines. This is definitely on the radar of the WHO, as I'm sure David can confirm. And at U4, we have done a pioneering paper on the link between corruption and falsified and substandard medicines, which is available on our website. And we found in that research that corruption affects the supply chain for medicines and results in falsified and substandard, all the way from manufacturing and distribution, regulation, procurement, and in the health workforce. So first of all, at the regulatory level, when regulatory officials collude with manufacturers and distributors by providing unwarranted certification or product approval, or by delaying approval of competitors due to conflicts of interest or collusion with criminal suppliers. And we also find that in that research that the procurement procedures prioritize low prices, sometimes over quality. And this may increase the risk of harmful products entering the system. And government officials, obviously, as we've mentioned previously and Mushtaq pointed out, through conflicts of interest and personal affiliations between officials and pharmaceutical companies or even criminal elements, lead to the proliferation of these kinds of products on the market. So I think that there are several things that can be done. And as one of the, as you pointed out, tech-based strategies are definitely one of the solutions to monitor and medical product quality and to reduce the amount of fake and falsified and substandard medicines on the market. So I think that it is definitely an issue of concern in many developing and developed countries. And the link with corruption is definitely there. It needs to be researched a lot more, and solutions need to be found. I'll post a link to the UFO paper in the chat so that you can read it for yourselves and know what the main issues are.
Thanks so much. Mushtaq, do you want to come in on this issue? Also, maybe you can expand on, using technology. Can technology be a panacea, or or are there more sort of entrenched factors, that technology cannot solve?
Yes, so I think technology is obviously extremely useful and it can help in lots of contexts, but it doesn't address the fundamental, on its own, political economy problem of enforcement. Let me give you an example. So we have done this research on absenteeism in a number of countries, in Nigeria, Tanzania, Bangladesh. In Bangladesh, the government has got fingerprint monitors in rural health clinics, and doctors and health workers every day check in with their fingerprint, and it is transparently known who is there and who is not. And this information is put up on a public website, and any citizen can go to this website and they have details of attendance in different health clinics. The absenteeism rate is 30 to 40% on an average day in rural health clinics, and something like 70% of doctors are absent at some point. Now, having this information doesn't help very much because there are too many absentees. And even if the Prime Minister comes on television and admonishes doctors, go and work, nothing happens. And if anyone knows the Prime Minister of Bangladesh, she can be extremely persuasive, but even she hasn't been able to make doctors go and go to work. So here is a political economy problem of enforcement, and I talked about this, earlier. So what we did in our research was we found that actually, when you have absenteeism, you have many different sorts of reasons why people are absent. Some of these reasons are legitimate reasons, and some of these reasons are not legitimate reasons. So I think the first step is to find out how you can reduce the absenteeism which is happening for legitimate reasons. For example, security is absent or their immunities are absent. There are no hardship payments for these difficult postings. If you can do that, and you can reduce the number of absentees from something like 70% at various times to something like 20%, you will then identify the real free riders and the real, problem cases. If you have too many violators, you actually can't do that. So our approach is you have to create a system where the horizontal checks between peers start working. If I am a university professor in London and I don't go to work, where does the first pressure come from? It doesn't come from my students. It doesn't come from my vice chancellor. It comes from my colleagues who say, you haven't come to work and we are having to cover for you. So this is not happening in a lot of the places that we are talking about. The horizontal checks are very weak because there are too many people violating for different reasons, and we need to get to the bottom of that. This is one very important problem. Once we have done that, technology may help, but technology by itself won't help if the knowledge doesn't result in action. And in many cases in developing countries, the knowledge is freely available. We know what the corruption is. We know who is corrupt. We know how it's happening. The problem is to create the incentives for action to be taken. That's the difficult political economy job. Technology is only one small part of that solution. Thank you.
All right. Thanks a lot. We'll just take one question, for all the speakers. It's from a participant online. How should international institutions, such as IMF, World Bank, WHO, deal with corrupt national governments? The person says, it appears that international financial institutions are willing to bail out corrupt governments as long as governments are willing to accept conditions of financial institutions, regardless of the consequences for the health sector. Yvonne, do you want to start?
In my opinion,
use the mic.
It is necessary
Please
to
use
draft.
the mic. Yeah.
Sorry. It's necessary to draft a guide for countries because the definition of corruption in different countries are different. In my country, the corruption is more as $2 and more. $2. This is the corruption. And you can be in the prison. It's not true. You have to revise the steps and limits. You have to, in this guide, the methods, anti-corruption methods, and the method of work for all organs which are involved in this activity. The training of personnel, the information of population. And I think we have to now, after the war, during the war in Ukraine, we have to improve public health system and public health emergencies. Is very big, is very dangerous. A lot of chemicals are now in this war, a lot. And we should to do something to inform countries to train the personnel, because about radioactive, all countries in this are trained. About COVID infection are trained. But about chemical, nobody say, but we have a lot of chemicals and big toxicity substances in territory of Ukraine. It is very important one. And to improve the capacity of preventive medicine. Because in some post-Soviet countries, the percent for prophylaxis, prevention, protection is more as 1% of budget of health of this country. Is very, very small one. Is not, and I finish. To focus the quality of medical services to ensure that patients are satisfied. This is very important indicators. Thank you.
Thanks. David, do you want to answer this tricky question?
I'm just going to go back to what Mushtaq said in his opening. I think there's a problem here of omission, not commission. I don't think any international agency goes out of its way to perpetuate corrupt activities. But I think we probably do need, as a group of agencies to think about how we can work more collectively to address this topic. We've talked a lot today about misconceptions about what corruption is, about how difficult it is to deal with. So I think there is a lot going on in relation to international agencies who do recognise that more needs to be done to address this problem. And that's why we have a network of international agencies, including most of the agencies that were listed in the question, who are serious about and trying to do more to reduce corruption.
Mushtaq or Monica, do you want to come in on the role of international agencies? Go ahead.
Well,
Yes, sir. I think I just want to add that, you know, part of the error of omission is to have the wrong analysis, right? So if the analysis is that what needs to be done is another dose of transparency and accountability, or if the analysis is that corruption is happening because of too many public subsidies and we need to cut those public subsidies, then that analysis is wrong and it doesn't help. So if the cure actually cuts public spending even further, it can actually drive more corruption. So this is just reiterating what David said. It is really important to have evidence-based analysis, which actually fits our knowledge, which has come from years and years of experience. And then that kind of analysis should inform reform. And often the reform is driven by abstract models of what drives corruption, which might be somewhat relevant to the advanced country experience, but is not relevant to the developing country experience. Thank you.
Yeah, go ahead, Monica. Tailoring solutions to the local reality, basically.
yes, I just want to say that conditionalities have been attached to international aid for forever. There's, as David said, none of these multilateral international agencies sets out to increase corruption, and aid usually comes with a conditionality concerning corruption, good governance, and all that. Without taking away from what Mushtaq and the others have said, the problem with those conditionalities is that they don't really have an enforcement mechanism other than reduced aid. You know, they use a carrot and stick approach of reduced aid if you behave badly, and more aid if you behave well. But there are two problems associated with this. One is that when countries behave badly and the aid donors decide to reduce aid, who's likely to suffer most? Is it the politicians or the poorest citizens in those countries? And they are well aware of this dilemma. The other problem is that aid recipient governments have learned to play this game really, really well. And many of them have learned to really play a game of smoke and mirrors, as Mushtaq said. They will apply, you know, they will meet the conditionalities by having nearly perfect anti-corruption framework. They'll have the laws, they'll have the institutions, they'll do everything that the conditionality says they'll do. They'll put in place all the guidelines for managing fraud and so on and so forth. And they'll be able to say, look, we met the conditionalities. But they really know how to, you know, play cat and mouse with the international aid system and put in place what's required without actually adhering to it. So it's just one of the weaknesses of the international system that there's no mechanism for enforcing these conditionalities, and that at the end of the day, nation states are sovereign, and there's only so much that donors can do to make sure that recipient countries behave.
Thanks so much. Yeah, there's a question. Go ahead, in the room.
Thank you to the organisers of this event. It's been a very interesting discussion so far. I wanted to pick up on something that both Monica and Preeti said. Corruption isn't just something that happens in LMICs, it's something that happens in HICs. As someone from the UK, whose Prime Minister is currently in the news for various corrupt practices, not to mention all the shenanigans during COVID. How do we ensure that these conversations don't end up in places where us in the global north are seeming to speak about both problems and solutions and trying to universalize from them? Secondly, if you'll permit me the mic. At the start of the conversation, we talked about 10 to 15% of wastage, to use the euphemism, going to corruption. When I look at that, I also see 85% to 90% not being wasted. So how are your programs looking at ways that compliance is happening and happening already? And how do we encourage those behaviors? Part of the reason I ask that is because anti-corruption efforts have also been used for various political reasons. I'm from Hong Kong, so China being a classic example of where anti-corruption measures have been used excessively by the party in some respects.
David, do you want to respond to this?
I thought it was to Mushtaq.
Mushtaq or Monica, do you want to respond to this?
Yes, so I think that, to open up this conversation globally, and I think it's really important, some of the issues that I talked about how the global pharmaceutical market and intellectual property works, how big pharma profits often drives underinvestment in developing countries and results in contract manufacturing, which is connected to political processes. These things need to be part of the conversation. They might not have easy answers, but I think if we are only talking about developing country corruption, it gives the impression that it's the kind of privileged North lecturing the South. And I think we have to have a much more open global conversation about what's wrong with the global health system. And part of the problem is indeed from the North. Now, it's important to understand that the way in which influence buying happens in a northern country happens through legal lobbying, and influence buying in the South often happens through illegal political networks and bribes and so on. But to me, if you are buying influence in illegitimate ways, it's something we should be concerned about. And I don't care if you call it corruption or something else. We should be concerned about how the powerful use influence in illegitimate ways, which harm the public, the global public. And I think that should be really the conversation. And some people would describe lobbying as corruption, and some people wouldn't. But I think we shouldn't get caught up in this definitional issue. We should be concerned about how to open up the global health system to more competition, more openness, and better service delivery. And that requires addressing both some of the legalized forms of lobbying, but also some of the illegalized or illegal forms of lobbying and illegal forms of influence that we call corruption. And I think both should be part of the conversation.
So thanks for that. We were actually talking about it before the session, and the part of the problem is that it's a gray area how lobbying is classified. And of course, COVID-19 makes these conversations really immediate in some sense. So how do we sort of, across jurisdictions, lobbying is characterized differently? Yeah. And not even, in some countries, there are no disclosure requirements as well. So how would you deal with that?
Just call it lobbying. So we can talk about corruption and we can talk about lobbying, and we can say both of them have damaging consequences, right? So we don't need to talk only about corruption, because a developing country will say, look, our businesses or our powerful people are making under the table transactions, but in your country, you have over the table transactions. You have big pharma companies making big contributions to presidential re-election campaigns, and that's completely over the table, but the effect is exactly the same. They are buying themselves a lot of political influence. And I think we should open up, the under the table should indeed be treated differently from over the table, but we should be concerned about how the powerful buy influence. And that is a concern. And that is how, the health system is being distorted globally. And I think the easiest way to deal with it is that, a lot of corruption is driven by legalized forms of activities which are dubious. So, for example, the ways in which the banking system in the West allows corrupt people to park their money, that bit of it might be legal, but it is actually encouraging illegal activities elsewhere. So the interface between what is legal and illegal should not be ruled out simply because one bit of it is legal.
Thanks. And we are here in Switzerland. So just last question from the audience, and maybe I come back to the panelists for last remarks.
Oh, thanks for choosing me as the last one. Thanks. I have two questions. Thanks to the entire panel for this very enriching discussion. First is for Dr. Clark. Dr. Clark, while the most of the corruption debate is happening on the operative manifestation of corruption, even coming from your presentation also. My question is that, do you think that the policy choices need to be careful in terms of bureaucratic arrangement which has spillover in the operational front? What I mean that, say, Professor Khan was talking about Ganashastha Kendra in Bangladesh, Zafarullah Chaudhury's rational usage of drugs, or even Health Action International. This is more or less out of discourse present day. Second is, say, again, context-specific contractualization of service in particular cases. Do you think this is also linked to the operative practices? And of course, I am also from India. So publicly financed health insurance, the medical insurance, and this is it has various ramifications in current present. And so that's why I'm saying that if the country doesn't have the legal structure, what is your take on that? And the second, very short, pretty sorry, first, Professor Mushtaq. Professor Khan, one thing that, so if you are, since you are critical of or also not very confirmed about the technology, what do you think about, so which form of governance we should adhere to? Liberalism, the new public management, which is currently going on, moralism? So, thank you.
David, you can.
Yeah, sure. So I think the nub of the question is, does poor system design contribute to corruption? Yeah. Yes. No, sorry.
That our policy choices
need
to be careful so that it cannot have the space for
Oh, yes, sorry. Of course. Yeah, undoubtedly.
Publicly financed health insurance. If
Yes.
there is no legal structure for an accountability of
Absolutely.
private sector.
Undoubtedly, that is a big problem. And I work on another important topic in global health, which is the role of the private sector in health systems. And it's the same. The fact that there isn't, in many countries, a strong set of institutional arrangements to make the health system work as it should is the reason that we have a lot of these problems. And I think Mushtaq said in his presentation that for a long time, donors haven't put any resources or effort into this particular area. They've put it into the wrong things. So I would certainly advocate for more effort to support countries to build governance arrangements and institutional arrangements which make sense for that country and that context. And that's a job for donors and also for WHO and other agencies that support the creation of context-appropriate institutional arrangements. And we don't think we've done enough on that. And we're starting to try and do more work in that area.
So I think we'll have to wrap up now because we are close to the hour. And it's good that we're concluding on the public health approach to addressing health sector corruption in some sense. So I really thank all of you for joining us today here and online, and to our speakers for making this a really lively discussion. Thanks so much. Over to Winke.
For joining us, and really great panelists, so very stimulating. For those of you who are online, in a moment you'll be directed to a very short survey. We would really appreciate taking a couple of minutes to answer those questions. We use your answers to make our events better. And once again, as I said at the beginning, the recording and a short video of the webinar will be available in a couple of days at the link in the chat box. And of course, please subscribe to our newsletter. This will keep you updated on our events. And last but not least, I wanted to thank again the whole team, Ellen, Dr. Ellen Roskam, Alessia Nicastro, Bettina Zago, who's up in the corner, Sarah Lafontaine, there you are, and Moin Hossein Alipur. So thank you to the whole team, and we'll see you at our next event, which is in 3 days. No, not in 3 days. There's something the 26th of March. Oh, it's April. Okay, wrong month. Anyway. And there's going to be a cocktail upstairs, so please join us upstairs for nibbles and a drink. Thank you to everyone.